Hi, good day, and welcome to the October 2019 American Academy of Clinical Toxicology educational webinar featuring the Forensic Special Interest section. I'm Rama Rao. I am one of the chairs of the Forensic Special Interest Group for AACT and the moderator. I'm Associate Professor of Emergency Medicine at Weill Cornell Medical College at the New York Presbyterian Hospital in New York City. I have no disclosures or conflicts, and I have a couple of announcements before we have a really interesting webinar that features both a clinical case and a lawyer performing cross-examination. The announcements include to thank you, first of all, for joining us. Our purpose is to educate, share experiences, and stimulate discussion. We invite everyone to ask questions, make comments, and participate in the webinar at any time during the presentation by typing your question or comment in the box at the right of the screen and clicking enter. Following the presentations, the speaker will respond to your questions and comments. The November AACT webinar will be held on Tuesday, November 5th, featuring the American Board of Applied Toxicology Journal Club. And as with almost all AACT webinars, today's presentation will be recorded so you can view it again. About an hour after the webinar, you will receive an email with a link to a webinar evaluation and a post-test for those of you who want to receive CME or continuing education hours. And finally, if you look at the right side of your computer screen, about halfway down, you will see a section titled Handouts. There you will find some materials relevant to today's discussion, as well as the learner notification PDF that provides the information and link to obtain your CE certificate. So now we'll begin. Today's webinar is titled Brain Behavior in the Courts and will be presented by Marcia Ratner and attorney Alan Bell. Dr. Marcia Ratner is a diplomat of the American Board of Toxicology. She earned her doctoral degree in behavioral neuroscience at the Boston University School of Medicine, where she trained in the Department of Neurology under the supervision of the late Robert G. Feldman, with whom she published numerous articles and book chapters. She subsequently completed a 3-year National Institute on Aging funded postdoctoral fellowship in the Department of Pharmacology and Experimental Therapeutics at Boston University School of Medicine, where she continues to serve as a project manager and compliance officer for the entire department. She is a member in good standing of the Society of Toxicology, American Academy of Clinical Toxicology, American Academy of Neurology, and American Psychological Association. Dr. Ratner regularly serves as an ad hoc reviewer for several professional journals, including Neurology, Neurology Clinical Practice, Toxicology, Clinical Toxicology, Food and Chemical Toxicology, and the BMC Pharmacology and Toxicology. Mr. Alan Bell is an attorney who prosecuted organized crime cases for the state of Florida before being poisoned by his sick office building. He founded the Environmental Health Foundation, advocating for victims of environmental injury, targeting prevention and treatments. His founding scientific advisory board featured scientists from NIEHS, ATSDR, CDC, EPA, and top medical schools across America. As a toxic tort lawyer, he teamed up with attorneys, including those portrayed in the films Erin Brockovich and A Civil Action, to help other environmentally injured victims in court. His story has been featured on NBC, CBS, PBS, the American Bar Association Journal, and newspaper and radio shows nationwide. He has been a featured speaker at several major universities. His best-selling book, Poisoned: How a Crime-Busting Prosecutor Turned His Medical Mystery into a Crusade for Environmental Victims, puts a human face on the toxic dangers assaulting us in our everyday environments. It is endorsed by Robert F. Kennedy and Harvard Law professor Alan Dershowitz. His work has been supported by former Vice President Al Gore and Gene Cernan, the commander of Apollo 17. As a former victim, survivor, health advocate, and legal avenger, Bell offers an aerial view of one of the most important global health issues of our time. And now the time is yours, Dr. Ratner, to begin.
Thank you, Rama, for that very nice introduction. So the case I'm going to be presenting to you was originally a workers' comp claim, and I'm going to review this case. It was published in Environmental Health Perspectives and presented as grand rounds at Harvard Occupational Medicine rounds at Harvard University. So I have no disclosures other than that I do occasionally serve as a consultant in toxicology and pharmacology to legal and investment firms. There's no specific conflicts in this case. So the learning objectives today will be to learn how to rigorously collect timely, relevant data for eventual use in a toxic tort case, learn to recognize common mistakes that can result in your data being excluded as evidence, and learn what to expect during a deposition and a Daubert hearing. At the end of our presentation, we're going to do a little mock cross-examination so you can get a feel for how data that's collected is viewed by the attorney. With that said, whenever I see a neurotox case, my evaluation has to begin with suspicion of that there was a neurotoxic exposure. Maybe a patient calls up, maybe a lawyer calls up and says, I think there's a toxic effect. From there, I'm going to review the medical records, maybe have a clinical neurologist or neuropsychologist perform some additional testing for me, and I'm going to look to see if there are conclusive findings. If the findings are subjective and we can't find data to support them, then we would say there's no disease, and you can see that here. Oops. I don't know what just happened. Sorry, 1 second. We would say there's no disease, if there are findings, if there are conclusive findings, then we're going to need to make a differential diagnosis of neurological disease of non-toxic origin versus neurological disease of a toxic or uncertain origin. And to do that, we're going to review the evidence of exposure. That may be what the person did for a living, what was their occupation. That may be where did they live, what was their source of drinking water. We're going to go through all of that evidence, and we're going to document that exposure to the best of our ability. If the exposure is ongoing, we're going to get biological markers of exposure. If the exposure has ended, we're going to get the records and make sure we get all the information we need. In these kinds of cases, if someone comes into the emergency room, we're going to have an onset that's acute. But a lot of times, people with brain damage from chemical exposures have an insidious onset. And so we're going to have to reconstruct the exposure circumstances. And to do that, we're going to maybe bring in an industrial hygienist to model the exposures, if that can be done, and reconstruct their work history and generate all of this data, evidence of exposure. Then we're going to look at the epidemiological data and the tox data in the literature to see if the findings are consistent with what the chemicals that our client or patient was exposed to. And finally, we're going to determine the reliability of the data obtained. And that's going to depend on the timeliness with which it was acquired in relationship to the exposure, how the data was handled, the laboratories that measured blood samples or urine samples. I generally like to repeat levels of any chemical because I've had labs make mistakes. And so I highly advise that whenever you have a legal case, when it comes to lab data, always have that data double checked. Now, if we have chemicals that can cause neurotoxic effects and we can rule out all other etiologies, then we can have a neurotoxic syndrome. If we can't do that, then we would say this is an idiopathic disease and it's not a neurotoxic syndrome. So what I'm going to do next is walk you through an actual case where we're going to apply this approach. So the first thing we're going to do is we're going to have a referral. So maybe the patient calls us, maybe the patient's lawyer calls us. We're going to talk to them. We're going to find out what their complaints are. And we're also going to pay close attention to their medical symptoms, their neurological symptoms, and their psychiatric symptoms. It's very important because sometimes the other medical symptoms may support the neurological symptoms. Conversely, sometimes psychiatric symptoms may be giving rise to what appear to be neurological symptoms in a case where we have sometimes people that have like a conversion disorder or a psychogenic a toxic effect where they feel that they're having a problem, but there's no actual neurological complication. So we're going to want to look at this information, again, their occupational history, medical history, and their personal history. Did they use and abuse substances that may have caused brain damage? Do they have hobbies that may be putting them at risk for brain damage? Okay, so we're going to document all this with proper tests. So I always use a medical exposure history questionnaire that I've developed over the years that has questions about work, environment, well water sources, drinking water sources. I collect all that data, then I interview the patient, and I use that interview information to augment what's in the questionnaire. Then the patient will have data from a general medical exam, a clinical neurological exam, if necessary, neurophysiological testing if they have neuropathy, full neuropsychological assessment, which we're going to talk more about, neuroimaging studies, which we're going to talk about in greater detail, and if necessary, nerve biopsies. But neuropsychological and neuroimaging studies are really what we're going to be looking at today when we're talking about behavioral changes, a toxic encephalopathy that can occur with exposure to neurotoxicants found in the workplace. People that are exposed to chemicals in the workplace or the environment may have acute symptoms of dizziness, headache. They may have motor sensory disturbances. I've already mentioned they may also have nerve conduction abnormalities. Their EEG can be abnormal. We're going to talk a little bit more about that, but about 10% of the population has an abnormal EEG anyway with no epileptiform activity. So EEGs can be good and bad in that respect. Neuropsych testing is very important to documenting the behavioral effects, and we're going to talk about the right way to do that. And then neuroimaging studies, the advantages of a CT scan versus an MRI, as opposed to something like a magnetic resonance spectroscopy, which might be used more in research. And then biopsies, again, if there was nerve conduction complaints. So there are categories of toxic encephalopathy. Many of you are probably already familiar with. We have acute intoxication. I think a lot of us, we're in Nashville, we know about that. And acute toxic encephalopathy, which can follow a severe acute exposure like we see with carbon monoxide poisoning. And then we have chronic encephalopathies. And these emerge more insidiously with chronic exposures where someone might be working with chemicals for a long time in a job, such as a painter who's painting for years, breathing in lower concentrations on a daily basis, and not arriving in the emergency room because of their exposure, but gradually building up an insidious effect on their brain, similar to what we might see to someone who's a glue sniffer or a paint sniffer, right? These people are sniffing paints for years. They may not come into the emergency room until they're very sick. So this case I'm going to present today is a 57-year-old man who presented to us with a history of forgetfulness and disorientation. So he was a painter, and we had to rule out what was causing his problems. And so the differential diagnosis in this case began with ruling out a vascular dementia. He's 57 years old. This could be multi-infarct dementia, vascular dementia. We also had to rule out normal pressure hydrocephalus and Alzheimer's disease. In this case, we didn't consider that it was mild cognitive impairment because the severity of his deficits were so severe that this would not be what you would see in age-related mild cognitive impairment. It was already severe enough that we were thinking this might be some kind of a full-fledged dementia. His past medical history included German measles and pneumonia when he was very young, a duodenal ulcer, a 30-year history of moderate drinking, 1 to 3 drinks per day, which he stopped doing about 10 years prior at age 48 years old. He's a smoker, smoked 1 to 5 packs of cigarettes a day. that was currently a smoker when we saw him. He also had a history of a subclavian artery occlusion or subclavian steal syndrome. So he was a painter and he'd be moving that arm around. Sometime he would get some acute dizziness and other problems, but that was not deemed to require surgery. And it eventually passed on its own. It may have been due to some of the work he was doing as a painter. He had been a painter for 40 years. He started working as a painter in the 1950s, and he continued to work as a painter through the 60s and 70s, with much of his work done before the establishment of OSHA and the EPA. He frequently worked in poorly ventilated areas. So as it turns out in those days, his employer, when they would paint the insides of walk-in refrigerators, many of us who work in labs, we know what a cold room is. They would paint the insides of these cold rooms, and to avoid the fumes of the paints getting out into the business, whether it be a restaurant or a grocery store, his employer would say, close the door and work in there with the door closed. So they would work inside these enclosed refrigerators with paints and solvents until they would become acutely intoxicated. And he and his coworkers would experience bouts of acute intoxication during this process, where they would become dizzy and nauseous, and they would go out, breathe in fresh air for a while, have a cigarette or two, and go back in and work some more. So a very unusual set of circumstances that we probably wouldn't see today, but in those days, this actually occurred. His hobbies included fishing, hunting, beekeeping, raising livestock, ham radios, singing and playing guitar, and he had an antique car that he stored. His exposure data, we were not able to get biological markers of exposure in this case because his cessation of exposure had occurred a few years before he saw us. So he had stopped working with paints because his employer had let him go because he was having trouble on the job. He had been the foreman of the paint crew at that point, and he was starting to have trouble on the job, and so his employer had let him go. So we were not able to get biological markers of exposure in this case. So we had to rely on the occupational history, and we had to rely on the biological markers of effect, which we're going to see. Those of you who are familiar with toluene and glue sniffers, you're going to see the MRIs coming up. Were very similar to what we would see in a glue sniffer or a paint sniffer. So his occupational history was very strong, that he had been a painter, and he self-reported symptoms of acute exposure. We felt were very consistent with what you would expect of someone getting acute intoxication from paint. At this point, I just want to remind everybody that the reference manual for admissibility of scientific evidence under Daubert allows you to use biological markers of effect in lieu of biological markers of exposure when you have very good documentation that the exposure occurred. Work records, modeling of the exposure levels, these kinds of things where you can show that the person was exposed. So under Daubert, you can use biological markers of effect in lieu of biological markers of exposure, provided you provide adequate support for that decision that says that these biological markers of effect are consistent with what we're seeing here. So our painter's chemical exposure history included lead, toluene, benzene, methylethyl ketone, methylysyl butyl ketone, formaldehyde, mineral spirits, naphtha, carbon tetrachloride, and methylene chloride. Many of these chemicals today are starting to be phased out. Those of us who do any home furniture refinishing or painting of your own house and are old enough to remember know that there's a lot less solvent in paints today. Methylene chloride, is metabolized to carbon monoxide. It's basically not even really used anymore. But back when he was exposed, all of these things were in the work environment, and he was using these on a regular basis. So one of the things I like to do is create a time exposure symptom line where I go in and look at the history of the person in their work and try to understand how this exposure relates to what we're seeing in the patient's case. And this is just an example of how I would lay it out. You could lay it out any way you want if you were creating one for a case, but this is how I do it. So the first question I have to ask when we're trying to make that differential diagnosis is, okay, if this is a toxic encephalopathy, is there information in the literature to support this? And Arline Soborg, the people from Scandinavia, you know, the Scandinavian Journal of Work Environment and Health, the Scandinavians did a lot of early work in solvent encephalopathy, and Arline Soborg came out with this paper back in the late 70s showing what he called chronic painter's syndrome. And so chronic toxic encephalopathy in painters today is pretty well understood. So we know this can occur, and we know some of the chemicals that we suspect to be involved. So this is the actual MRI of this patient. And so we can see some diffuse cortical atrophy in this case, but we don't see disproportionate atrophy of the medial temporal lobes as we would expect to see in Alzheimer's disease. I've got a bell ringer later on because I actually followed up on this case 15 years after it was originally published, and I'll get to that in a minute. But so we looked at this MRI and we felt pretty confident that this was not Alzheimer's. Just to discuss the advantages of an MRI versus a CT scan in this case. So this patient had previously had a CT scan. We gave him an MRI, and there's actually a neuroradiologist who's a co-author on this paper, because MRIs are better able, because of the way an MRI works, you're looking at water concentrations. The image resolution of an MRI for looking at cortical atrophy is better than a CT scan, and so the MRI is what we relied on for our differential diagnosis. I also want to point out that the MRI and the CT scan are conventional clinical imaging tests, and these are admissible in evidence in all settings. But the functional imaging tests, like a PET scan, SPECT scan, fMRI that we might use in research, those may not be admissible as evidence in a toxic encephalopathy case because they're not generally used to diagnose a single person. They may be used to differentiate one group of subjects from another group of subjects based on statistical significance, but they don't have the support as a diagnostic tool. Okay, so this is the actual MRIs of patients that have different disorders. So in the top left-hand corner, we can see normal pressure hydrocephalus. You can see the enlarged ventricles that we don't see in the painter. In the case of vascular dementia, we can see the periventricular lesions in the white matter indicative of vascular dementia. And in Alzheimer's disease, we can see the severe atrophy of the medial temporal lobes. So these three examples are what you would look at to say, okay, how does this MRI compare to with the cognitive problems this man has? How does this MRI compare to what we would see in these other diseases? All right, so now we did get a blood lead level on him. It was back to the upper limit of normal at that time. He had an abnormal EEG with some increased theta activity and a little bit of sharp activity in the posterior quadrants, but he didn't have any seizures, so we would say this falls within the 10% of EEG abnormalities that we consider idiopathic. Neuroimaging, as I mentioned, we see the global atrophy, the cerebral atrophy. Neuropsych assessment, we repeated the neuropsych assessment. So we did an initial assessment, showed memory and attention problems and evidence of some reactive depression. And then we repeated that. We followed up and repeated that. And we saw that these memory and attention deficits persisted, but they did not get worse. And that's really important because with an idiopathic neurodegenerative disease, we would expect progression, not that the deficit would be static. So just a little discussion here of neuropsych tests and what kinds of tests can be admissible as data. So when you're choosing neuropsych tests, you want to make sure that you choose validated and conventional neuropsych assessments. You may not be doing this yourself. You may involve a neuropsychologist who's doing this on for you. If they have some unusual test that they develop themselves, or they want to use a test that's not typically used for assessing human function, like culture fair, which is only sensitive to one aspect of psychomotor function, but might not pick up memory deficits. Those kinds of tests would probably be excluded as evidence or attacked by an attorney. So you want to be sure to use conventional, widely accepted tests like the California Verbal Learning Test, the Wechsler Adult Intelligence Scale. The tests also need to be developmentally appropriate. You don't want to use an adult test in a child, okay? And they need to be clinically valid. If the patient is complaining of memory deficits, you don't just want to give them a couple tests of psychomotor function like on culture fair. You want to make sure you include tests of memory function that are going to reveal the deficits that the patient has. And then you need to show that these tests are sensitive to neurotoxic effects. Neurotoxicants don't tend to cause the kinds of verbal deficits we see with an aphasia due to a stroke. And so you're going to want to have tests that are going to reveal subtle differences in motor processing speed, attention, executive function, which are going to be more sensitive to toxic exposure. So the test battery that the neuropsychologist uses should really be tailored to also to get at the kinds of effects you expect to see. This is really important to understand, because if you're working with a neuropsychologist, you want to make sure that this is how they function. You don't want to get involved with somebody who might be doing things where their data is not going to be as admissible as evidence later. So in the case here with this patient, we use the Wechsler Adult Intelligence Scale, the California Verbal Learning Test, the RAIA Authorized Complex Figure, Trails A and B, Wisconsin Card Sort, Group Pegboard, and the Boston Naming Test. These are all conventional tests, and so this is the kind of test that we would use. I just wanted to give these as an example. Those of you who are familiar with neuropsych assessment, I'm sure understand and recognize these tests. The other thing we always do is we look at the school records and occupational records. This man was a foreman of the painters, so he was doing pretty good before he got sick because he had gone up to the level of being the foreman. He was the boss. And we also use hold tests. One of the tests that I like very much is the TOM, Test of Motivation and Memory. It's going to get in there, and it's going to identify whether the patient is putting forth enough effort. And if they're not, this may reveal malingering, but we don't typically say that. We just tend to say the data, the test results can't be interpreted. But you definitely want to have these data make sense in terms of what you're seeing on the neuropsych assessment to these school records. If the patient had a developmental learning disability, they might show a verbal IQ lower than their performance IQ because they might have had a deficit while they were acquiring language skills. So these school records can be very helpful when you're trying to establish your differential diagnosis. There's limitations, of course, to any neuropsychological test. There's floors and ceilings for patients with high and low intelligence. A lot of tests are good for localization of injuries and not necessarily suitable for looking at a toxic encephalopathy. Subtle deficits may not be possible to detect. One of the things that often happens with patients who have been exposed to chemicals is they go to 3 or 4 doctors before they get to a toxicologist who knows what they're looking at, and they've started to recover with cessation of exposure depending on the severity of their deficit. And so you won't pick those up. You won't pick up those subtle deficits. Cultural limitations, native languages can interfere, and timing of tests. But as I just said, really important to try to have those neuropsych tests as close to the cessation of exposure as possible, and also to have serial testing so you can see if the encephalopathy progresses, shows recovery, or is static. So in this case, we formulated this opinion based on ruling out the following. The Alzheimer's disease, he had an atypical age of onset. There was no anomia, which is a classic hallmark of Alzheimer's disease, is a word-finding problem. And serial testing revealed that his cognitive deficits were not progressing. Learning disability was ruled out in this case because his verbal IQ was actually greater than his performance IQ. And that's important because a toxic encephalopathy tends to show that. It actually tends to show a verbal IQ greater than a performance IQ. And we have a guy here who was a painter. We would expect him to have a pretty good performance IQ because he worked with his hands. There's no evidence of stepwise progression, so we were able to rule out a vascular dementia, and the MRI didn't support that. The subclavian stele, the memory deficits associated with subclavian stele tend to be transient. We didn't see that here. We ruled out he was a hunter, Creutzfeldt-Jakob disease and other viral dementias were ruled out because he didn't die. It didn't progress rapidly. We didn't lose him. We also ruled out normal pressure hydrocephalus based on the ventricles not being enlarged. The previous head injury, he had a small head injury as a child. He didn't lose consciousness. He was just kind of dazed. We didn't consider his head injury record to be important. But if he had been a football player who had repeatedly had head injuries and a toxic encephalopathy, we might think this is chronic traumatic encephalopathy. Now, here's the bell ringer. I followed up with this patient 15 years after, and he never developed Alzheimer's disease, and he never got completely better either. He continued to have problems. So the differential diagnosis stands. I never saw any reason to change that. He unfortunately passed away a few years ago, but he never developed AD. With that, here are the references, and I will turn the floor over to Alan Bell after a couple of questions. So I guess we have a couple polling questions. Rama, do you take it from here?
Oh, sorry. Yes. I guess what we can do is we can ask Alan Bell. Is he still on the line?
Yeah, I'm still on the line. Yes.
Okay, great. Are you able to activate? What we can do is, if you want to do the poll maybe at the end, is that possible? Just in the interest of time, because I think the cross-examination will be so interesting. And I think that having Alan
do you see me on there or no?
Not yet. I guess I'm being instructed that you need to do the poll. So maybe we could do the poll. Which of the following mistakes may result in data being excluded as evidence? Improper timing of neurological, neuropsychological testing, use of novel investigational methods, lack of objective biological marker, or all of the above. And maybe now you can type that in, because I'd love to skip to the presentation by Alan, mostly in the interest of time. I don't know if the administrators can, and then we can loop back to this, if that's all right with everybody, because we only have 25 minutes left in the session. So is it possible to activate Alan Bell's presentation?
Okay, I don't.
Is it possible to go back to, okay, Alan, now all you have to do is press on your presenter slides, if possible, on your PowerPoint.
How do I do that?
Okay, you go down to your PowerPoint. Yep, right there. And open up your AACT PowerPoint. Nope, you were in the right place. Go back to your PowerPoint. Okay, great. And then go to that presenter in the bottom corner. Yes, exactly. There you go. Fantastic.
Oh, so shall I begin?
Yes, that'd be wonderful. Thank you. Sorry for the technical difficulties.
Okay, so now it's time to take you from your medical world into my legal world. Now, you were never taught in medical school what I'm about to share with you. When you are dragged into the legal arena as an expert medical witness, your credibility will be attacked by defense counsel, jeopardizing an adverse outcome in your patient's legal case. So what is a toxic tort case? It is when a person or a group of people are exposed to environmental toxins, causing illness or death. So to seek justice, the victim or your patient sues the person or legal entity whose negligence or intentional action caused their injury or death. The defendant will invariably deny liability based on the litany of typical defense tactics. Some of these tactics are as follows. Well, your patient is a malingerer, Or even if a valid medical condition exists, someone else must have caused the injury, not our client. Or maybe the defense would be your patient was exposed to other toxins in the past that caused their illness. Or maybe the patient was negligent, him or herself, and contributed to their own demise. So these are some of the defendant's playbook, okay? The case usually boils down to a battle of the experts. You, as the expert or treating physician for the plaintiff, will go up against the expert hired by the defense. The strategy of each side is to discredit or try to exclude the testimony of each other's expert. So let me repeat this. The defense will try to discredit you and try to exclude your expert testimony. So you are the forensic key to prove each toxic tort case. And every new patient that walks into your office, you are on the front line of a new potential toxic tort case. How you handle each patient from the moment he or she walks in through your door will determine the outcome of your patient's legal case. Your front end medical role determines the back end legal outcome. So as a toxicologist in a legal case, you will be wearing one or two hats. Hat number one, you are the treating physician. And or hat two, you will also be an expert causation witness who connects the toxic exposure to an injury or illness. If you fail to connect these dots as the treating physician or expert witness, your patient will lose their case because you are the detective. It's up to you to find out who or what poisoned your patient. Before a toxic case even appears on the radar screen, always anticipate a lawsuit. And as you practice defensive medicine to cover your own back, practice medicine with the expectation that your patient may end up suing the entity who injured them in the future. So let's talk about what you need to do to prepare for a legal case as a treating physician. Number one, take a detailed history. Hone in on the environmental exposure that caused the injury or illness and rule out all other exposures, whether they be previous or simultaneous exposures that did not cause the medical condition that you are treating. You are acting as a detective, searching for an environmental culprit that caused your patient's condition. Ask your patient about previous toxic exposures in their lives. Ask them if others have been adversely affected in the environment that your patient was poisoned in. Number two, carefully document symptoms and physical examination that you conducted. The time of onset of specific symptoms relating to the time of toxic exposure is a valuable clue linking the medical condition to a specific exposure. For example, if your patient walks in and says, "Doc, every time I go to work, I get a headache, a runny nose, burning eyes," you might ask, have other coworkers felt the same? Was the building recently renovated? Probative questions like this are essential. Number three, collect biological samples, whether they be blood or tissue. Timeliness of this is critical. The sooner the evidence is preserved, the better, because this evidence is like a stealth bomber doing its damage in the middle of the night, and unless it's documented real time, the proof is forever lost. And then finally, take these samples and store them properly to avoid inaccurate lab results, and adhere to a strict chain of custody to make sure that the samples are not contaminated. Number four, order diagnostic tests, but to be admissible in court, these tests must be conventional, not research-based. So accordingly, stay away from relying upon unconventional research-based tests like an fMRI or a PET scan or a SPET scan. The diagnostic tests that you perform, the physical exam that you conduct, and the notes in your medical records can make or break your patient's legal case. So the bottom line is this.
Can I interrupt? Oh.
Yes.
I'm sorry to interrupt, but I'm not sure if you have slides advancing.
I
that
do,
are related
but no,
to... Okay,
they're not advancing yet. They're not advancing
okay,
yet.
very good. Sorry.
Okay. I'm making it simple. So all they got to do is listen. Most of my slides are very few and far between. So the bottom line is this: the legal goal in your efforts is to link specific exposure to the illness or death of your patient and rule out all other exposures or causes. So your involvement in a toxic tort case occurs in 4 phases. Phase number 1, you will speak with your plaintiff's lawyer and provide him or her with your patient's medical records. And if the lawyer determines that there is a valid legal claim, it can be proven, the lawsuit would be filed. Phase number 2, you will appear in a deposition. Phase number 3, you will testify in the Daubert hearing, and the defense will attack your credibility and your expert opinion. And finally, phase 4, you will testify in court in a jury trial, and we're going to demonstrate that later on. So the next slide is your deposition. Your performance in the deposition is critical. You will be asked hundreds of questions by the defense, probing for ways to find weaknesses in your patient's case. Their questions will attempt to discredit you, your patient, and the way you practice medicine, and your expert opinion in your case. Your education, your experience, your training, the validity of diagnostic or biological tests that you ordered, the tests that you should have ordered but didn't, the symptoms or physical abnormalities that you did not observe, and the points that you failed to document in your file are all ways that they're going to attack you on. The defense's goal is to sell the jury on an alternative theory of causation, totally unrelated to the toxic exposure that hurt your patient. They may bring up studies, journals, medical books that contradict your diagnosis or your expert causation opinion. The defense may lull you into believing they are throwing softball questions at you, but don't be fooled in this deposition. They're simply learning what you know and what you don't know and set you up with surprises in front of a jury. And I'll show you how the defense does this later. So the next phase is the Daubert hearing. Before a jury trial is scheduled, the defense usually tries to prevent you from testifying in front of the jury. And because without your testimony, the plaintiff's case is dead. Without your testimony, they cannot prove causation. A typical defense tactic is to attack your expert opinion by claiming it is not credible and lacks a valid scientific basis. The defense will initiate what's called a Daubert hearing. This hearing is based upon a United States Supreme Court case decided in 1992. So let's look at this case, the Daubert hearing. Where are we here? Let's look at this case. The rule of law in the Daubert case, which was decided in 1992, is this: the scientific principle relied upon by the expert must be based upon reasoning and methodology that is scientifically valid. This law allows emerging yet valid science to be heard by a jury, and there's 5 factors that a judge uses to decide if reasoning and methodology is scientifically valid under Daubert. And these 5 factors are this. Number 1, has the theory that your opinion relies upon been tested? Number 2, is the theory peer-reviewed? Number 3, what is the theory's potential rate of error? Number 4, what standards control the operation of technique? And number 5, is the theory generally accepted by the scientific community? The case dictates how a judge will act as a gatekeeper and of evidence in a jury trial, and only allows the jury to hear expert opinions based upon sound, valid science. If a judge decides an expert opinion is based upon junk science, the judge will not allow the jury to hear your testimony. Here's how you're involved. in this hearing. You will appear before a judge. You will get on the witness stand, and you will tell the judge your expert opinion, which will be this. In essence, the toxic exposure caused your patient's illness or demise, and then you will provide the scientific basis for that. If the judge decides that your expert opinion is valid and is based on valid scientific principles, you testify and your case moves forward. Your testimony must be based on scientific principles or it will be excluded. So the next phase of your involvement is the jury trial. And that's when you get on the witness stand. And when you testify, be strong, confident, and when answering questions, look at the jury in the eyes. Don't look off in the distance. If any of your testimony at trial conflicts with what you stated in your deposition, the defense will throw it in your face to attack your credibility. Make sure you read your deposition transcript carefully before you testify at trial. Here's an example in Dr. Ratner's pain case on how the defense counsel will attack your expert opinion. Let's say the defense will ask you about studies that you relied upon that concluded that the pain exposure caused the toxic encephalopathy. They will punch holes in these studies and throw other studies at you that conclude that pain exposure does not cause this particular encephalopathy. So do your homework and know that all scientific studies exist, whether for you or against you, before you walk into the courtroom. So in conclusion, toxic tort litigation is an emerging practice and specialty of law. It is following the trend of increasing illness and death related to toxic exposures. And as you well know, studies show that 1 of 2 men will get cancer. 1 of every 3 women will get cancer. And our federal government tells us that 80% of all cancers are caused by environmental exposure. So more people become ill or die from environmental exposure than all those afflicted with AIDS, accident, war, and crime combined. So other than war, crime, or accident, illness and premature death is caused by only 2 factors. Number 1, the genes that you're born with. And number 2, the environment that we are exposed to. This is why the field of epigenetics is exploding. And you, as toxicologists, are on the front line of this silent epidemic. You are the unsung heroes who devote your careers to making a difference in the lives of many. I applaud your valiant efforts in making our world a better place for all of us. And I thank you. So we move to phase 3 now, which is a mock cross-examination of Dr. Ratner. So let's use Dr. Ratner's painter's case and assume that the painter has sued the paint manufacturer of the paints that her painter used over a period of 15 years. His lawsuit claims that pain exposure caused his encephalopathy that destroyed his life. And Dr. Ratner is the expert who is the only one that proves causation. And that causation is that his pain exposure caused the encephalopathy. And without her conclusion on connecting the dots, the painter has no case. So we're going to now demonstrate with you on a sample mock cross-examination of Dr. Ratner. And we're going to pretend like she's on the witness stand in trial. And I'm going to pose as the attorney representing the paint manufacturer. So I'm going to be the adverse attorney trying to discredit her. Assume that she has already testified in cross-examination, which was in essence the demonstration that she's just given you, and explaining how she worked up her case, how she determined causation, which is really proving the plaintiff's case. Now I'm going to come in on cross-examination, and I'm going to try and poke holes in her testimony. And now through my aggressive cross-examination, I'm going to try and create doubt in her expert conclusion. So may we proceed, Dr. Ratner, with the mock-up cross-exam?
Can everyone hear me? Rama, can everyone hear me? I don't think people can hear me, Alan.
Yes,
Oh.
you can be heard. You
Oh,
can be
okay.
heard.
Okay, Alan, go ahead.
Okay. So the first set of questions, what I'm trying to do is, so you know up front, as a defense attorney, I'm trying to set her up by establishing how precise the system expects her testimony to be. The legal system, how precise her legal system, our legal system expects her testimony to be. And what I'm doing is I'm trying to show what a high bar the legal system is. And then I'm going to try and dilute her testimony by impeaching it. So I'm going to start off with the first question. So Dr. Ratner, you sat here in front of the jury in open court today, and you raised your right hand to tell the truth, correct?
Yes.
And you testified on direct exam that your painter's exposure caused his toxic encephalopathy. Is that correct?
Yes.
And because of his injury, he sustained significant damages, correct?
Yes.
So now I'm basically putting it out there that she's sworn to tell the truth and that we expect her testimony to be accurate. And now I'm going to try and chisel away at her testimony. The first thing I'm going to do is show that she took an inconsistent patient history compared to what she's already testified to by showing an inconsistency in her testimony. So here we go. Dr. Ratner, I asked you to refer to page 3 and line 4 of your deposition, where you stated that your patient came into your office and you took his history. And you included in your historic notes at that time that he drank alcohol 3 drinks a day. But you didn't mention the alcohol today, did you?
I believe I did.
Well, you included it.
That he drank 1 to 3 drinks per day.
Okay, but you didn't make a big deal of it in your testimony today, did you? You just sort of glossed over it, didn't you?
No, I did not feel his alcohol use was excessive.
Okay. Well, it was important enough to put in your notes, though, wasn't it?
It was important to consider how much alcohol he consumed, yes, because he may have consumed more, but I didn't consider his reported alcohol consumption excessive.
You also included in your notes, Dr. Ratner, that he smoked 1.5 packs of cigarettes a day, didn't you?
Yes.
But you didn't include that in your testimony today either, did you?
No, while toluene and other benzene derivatives occur in smoke, I didn't consider that source of exposure would cause the severe cognitive deficits he has.
Okay, class, so now I'm going to go on another set of questions, trying to chisel her testimony further by showing some more inconsistency in the patient history that she took. So, Dr. Ratner, on direct exam, you mentioned mood swings as a symptom, didn't you?
Yes.
But you didn't list that symptom in your medical notes taken years ago, did you?
No, I did not. And that's because depression can cause memory problems and concentration problems. And I was concerned with the depression as if that were the only factor in his history as a cause of his cognitive problems. But the mood swings per se would not be expected to cause his cognitive problems.
But your memory 2 years later, and mentioning on examination today, is clear, and the importance of it was more significant today than it was 2 years ago, huh?
Well, I think the mood swings are an indication of his organic affective syndrome from his exposure. But as far as the mood swings causing his memory or attention problems, I didn't need to rule out those. I wanted really to rule out a standalone depression as the etiology. If there was no history of chemical exposure, I would be thinking that his depression was causing his cognitive problems.
Okay, so class, we move on, and now I'm going to demonstrate some lack of corroborating evidence to support her expert opinion. And the question is going to go like this. So, Dr. Ratner, you have nothing to indicate that other coworkers were injured like your patient was, do you?
No, that is true. That is correct.
Okay, now the next question, class, is going to attack the issue of causation. So Dr. Radner, isn't it true that your patient never got much better after his exposure to my client's paints?
That is true.
And even after the paint exposure was stopped, he still didn't get better, did he?
That is true. However,
and isn't it true? Go ahead.
I'm sorry. However, toxic encephalopathy can persist indefinitely after cessation of exposure.
But isn't it true also that if our paints were the cause of this illness, that it's possible that stopping his exposure could also stop his symptoms?
Yes, that would be true.
But his symptoms continued, didn't they? Even after he stayed away from these paints for years.
Yes, his encephalopathy is very severe, and it's not a reversible, mild type of pharmacological effect that one would expect with an acute intoxication, but a persistent brain damage due to the chronic exposure.
Okay, so the next question is going also to attack causation class. So, Dr. Radner, it's true that after your patient was exposed to our paints for over a decade, which was 5 years before the onset of these symptoms, your patient had a CT scan that was normal, wasn't it?
That is true.
And the only thing they found at that time was an occlusion of the subclavian artery, correct?
Well, the CT scan was done because he had subclavian steal syndrome. So just to qualify that, the CT scan was done because he had a complaint of subclavian steal syndrome symptoms.
But the CT was normal, wasn't it?
Yes, but the resolution of a CT scan for looking at cortical atrophy is not as strong as an MRI. An MRI is a much better neuroimaging technique to detect the type of atrophy that he has.
So, Dr. Radner, is it fair to say that at that time, after he was already exposed to our paints for years, there was no finding of encephalopathy at that time, was there?
Well,
Okay.
the CT scan was normal, but his wife had noticed his cognitive problems before he sought medical attention for them.
But my question is there was no finding of encephalopathy at that time, was there?
Not on a CT scan, no.
Okay.
And the patient had not sought help for his problems at that time.
Okay. So the next question, class, is going to showing insufficiency of evidence that I'm bringing out.
Before you do that last question, I just wanted to say, those of you who need to leave, this will be available for access at a later time, because I know the 1 hour mark is coming to a close, but for those of you willing to stay on the line, we can go over, because I think this is probably a very engaging portion of the webinar. So thank you very much, and we'll see you next month. But those who want to stay on the line, we'll continue the webinar. Okay, go ahead, Mr. Bell.
So, Dr. Radner, isn't it true that biological markers were not obtained to document exposure at the time of the exposure? Isn't that true?
We did not obtain biological markers of exposure. Yes, that is true.
And that's basically because you saw him years after he quit work, right?
That is true. So we had to rely on biological markers of effect and his exposure history.
Okay. And Dr. Radner, your patient was an antique restorer, wasn't he?
He did restore a car that he owned, yes.
And antique restoration and restoring cars requires the use of toxic paints and strippers, doesn't it?
That is true.
And exposure to these paints and strippers can also cause toxic encephalopathy, can't it?
If there was enough use of those, it could, yes.
Okay, so let's move forward and show I'm going to show now lack of diagnostic evidence. I'm going to bring this out. So, Dr. Radner, you did not order genetic testing, did you?
No, we did not.
Wouldn't you agree that this type of genetic testing could be helpful in finding out what caused your patient's illness?
Yes, but it wasn't widely available at that time. But if this patient were seen today, I would order it.
In fact, sorry, go ahead. So in fact, glue exposure causing toxic encephalopathy is well known in literature, isn't it?
Yes.
And other than what your patient told you, you have no way of knowing whether or not he was a glue sniffer, do you?
No, he could have been. I don't know.
Okay, so Dr. Ratner, based upon your conclusions on your patient's history, the MRI that you ordered, the symptoms that were obtained, the examination and other testing that was done, isn't it true that exposure to glue could result in the same diagnosis and have the same MRI results?
Yes, if he was a huffer, he might have similar results, and he certainly didn't admit to that. If he was doing that, he didn't admit it.
Okay, also, Dr. Ratner, isn't it true that your patient did not wear a respirator at the times he was using the paint?
That is true.
And don't you agree that wearing a respirator could have prevented or mitigated the onset of his disease?
That is true.
So I'm asking these questions, class, to show that there could be some degree of contributory negligence. And I'm trying to bring this out through the plaintiff's own expert, who is Dr. Ratner, by showing through his own expert that he himself was comparatively negligent in causing or contributing to his own demise. So another follow-up question would be something like this. So Dr. Ratner, would you agree that, that your patient did not ventilate the areas that he painted while he was painting?
Yes, that's true. But he was told to go into those areas by his employer.
But nevertheless, he did not use ventilation, did he?
No, no.
And would you agree that ventilation could have mitigated or prevented his injuries?
Yes, yes.
Okay. So finally, Dr. Ratner, I'm going to ask you a few more questions. You wrote in your report that, quote, the exact chemicals cannot be ascertained. Did you not write that?
That's correct, because we didn't have, every paint and thinner and what he used. We had some material safety data sheets and his history, but he may have used chemicals that were not in that we were not told about.
So in general terms, isn't it true that the actual exposure of toxins, whether they're ingested, inhaled, or touched, is what causes human disease? Wouldn't you agree to that?
It can, yes.
And wouldn't you agree that if there is any residual of a suspect chemical remaining on or inside a victim's body, there's no way to conclusively ascertain the exact chemical exposure, is there?
I'm sorry, you're asking where that chemical came from?
No, what I'm saying is if there's no way of actually showing that there's a chemical residue in or on somebody's body, there's no way of conclusively showing that it was ingested in his body. You can only do it circumstantially. You can't do it directly.
Right.
Correct?
In this case, he had to rely on the circumstantial evidence of his exposure history, the chemicals and the types of chemicals that he was known to use in his occupation, and connect that to the biological markers of effect, which were consistent with peer-reviewed reports in the literature of exposures to the chemicals that he used.
So is it fair to say that there's no way of concluding without any doubt as to what the exact chemicals were that your patient was exposed to?
That would be true.
I have no further questions of this witness. So these are some examples of how a defense attorney is going to try and punch holes in the expert witness's testimony. And as you could see, a lot of these questions that I asked Dr. Ratner had absolutely nothing to do with her competence or her expertise. I was basically trying to show the jury through targeted questions what the weaknesses are in the case as it is, that she has no control over. As an expert witness, you have no control over the evidence. All you could do is do the best you can and testify accordingly. And there's always gray areas in every case, and there's always holes that a defense attorney can punch into the case. But I could tell you this, that I have had a huge case with Dr. Ratner that ended up on the cover of the American Bar Association Journal and ended up in legal journals and medical journals all over the United States. And Dr. Ratner on the witness stand is as good as it gets. She is unbelievable. So that's all we have to offer.
Yeah, that was so exciting actually to hear that and to listen to the way that Dr. Ratner answered those questions. We have a few questions from the group, but I'm wondering if you could, Mr. Bell, tell us what were the characteristics that made her so good as an expert witness?
That's an excellent question. Well, first of all, it's her expertise. She is one of the very few neurotoxicologists in the country, and she's at the top of her game in that subspecialty. So she walked into the courtroom. She knew exactly what studies were against her, what studies were for her. She has had a lot of experience in testifying in court before, so she walks in with a sense of confidence. The juries pick up on this, and you have to remember that you've got 12 laymen that are sitting in the jury box that are trying to digest very highly technical information. So it's very important for you as a doctor and an expert to boil it down to something that an average person can understand. She's very good at doing that. And she did her homework. And as far as, you know, all the things that I lectured upon, that she makes sure that she takes a very good detailed history. She makes sure that she reads her deposition before she walks into court, so she knows she remembers everything she said in the deposition. And if there are any inconsistencies, she's ready for the cross-examiner to come at her with that question, because she already has the answer as to why maybe she didn't mention it in her deposition and she's mentioning it at trial, or the opposite, and why she mentioned it in her history, but she didn't mention it in a trial. So that takes experience.
And then I have a few questions from the audience, because that was very helpful to hear that, and to hear that Dr. Ratner, you weren't very impassioned one way or the other. You just sort of stated the facts, which seemed to be very effective. There's two questions from Dr. Alan Wolf and one from Dr. Krenzelach. One question from Alan Wolf is, what is the difference between the expectations of a healthcare professional serving as a fact witness versus an expert witness?
That's a very excellent question. The answer is this: a fact witness is the treating physician. So you get a patient that walks into your office, you take a history, you do an exam, you order diagnostic tests, and you treat that patient. That's a fact witness. An expert witness is, the expert witness gets all the fact witnesses' medical records, and the expert witness will even get the fact witness's deposition. And the expert witness will come over all of the facts and all of the history and come up with an expert opinion that's totally isolated to one issue, and that is the issue of causation. So as an expert witness, you basically review everything that the fact witness did, and you come to an independent conclusion that, you know, based upon all the facts, it's your expert opinion that this exposure caused this injury, causation. Now, in many instances, the fact witness is also the expert witness. They basically treat the doctor, they treat the patient, and they act as the causation witness as well.
Okay, and then another question sort of on this similar topic for you again, Mr. Bell, is does DOBER apply to both the patient's treating physician and the expert witness? Kind of a follow-up on that.
Again, an excellent question. The answer is it only applies to the expert opinion on causation, because the fact witness is basically recording facts. So facts come into evidence. There does not need to be a gatekeeper to decide whether a fact comes in or not. All facts come in. But the issue of causation, where an expert gets on the stand and tells a jury, you have to rely on me as an expert, and I am telling you that exposure to this substance, this paint, caused this toxic encephalopathy. So the jury's relying upon that expert opinion, and a judge is going to be very careful to limit only those expert opinions that relied on sound, scientific, theory.
Okay, great. Now we have time for 2 more questions because we've already gone over and many people are having to leave. Another question for you, Dr. Ratner, is there, this is from Alan Wolf, is there a neuropsychological testing signature that is pathognomonic for solvent encephalopathy?
Yes, so solvents tend to affect dynamic cognitive processes like learning and memory function, attention and executive function, psychomotor speed. These are dynamic processes. Information that was acquired long ago, such as language skills that could be affected with a stroke, for example, tend to be more resistant to a solvent encephalopathy. So the diffuse injury that a toxic encephalopathy causes tends to result in a clinical presentation with a solvent encephalopathy that is affecting more dynamic cognitive processes. So you're looking for performance deficits on trails A and B, time tests where there might be psychomotor slowing, memory function, because encoding of new information and consolidation of new information are dynamic processes. So you would look for deficits with acquisition and learning of new information, whereas old information that they learned before might be preserved. So that's the kind of signature that you would be looking for on neuropsych assessment.
Okay, thank you so much. And then Lauren Murphy asks, are the attorneys allowed to ask leading questions?
That's a very good question. And the answer to it is, on direct examination, where the patient's lawyer, who's the plaintiff's lawyer, puts Dr. Ratner on the stand and asks her questions, they cannot be leading. They have to be, well, Dr. Ratner, what did you find? Instead of saying, Dr. Ratner, didn't you find this? That's a leading question. So you can only ask a direct questions that are not leading on direct exam. Now, in cross-examination, where the adverse lawyer is questioning Dr. Ratner, and I was posing as the adverse lawyer in this little mock trial just now, and every single question I asked was leading. Isn't it true this? That's leading. Isn't it true that? Wouldn't it be fair to say this? Don't you believe that? Don't you believe that? Don't you believe this? Isn't it true that? Those are all leading questions, and on cross-examination, you're going to get that. And you're always going to get that from the lawyer on the other side. So you got to be really tough in answering those questions, those leading questions. And that's why we wanted to show you through Dr. Ratner on how she handles these leading questions, because they're tough. It's basically a lawyer that's trying to put his words into your mouth. Isn't it true that glue could have caused this? I mean, you're on the stand basically trying to show that the paint caused the encephalopathy, but now you've got an adverse lawyer that's saying, well, glue could cause it too, can it? And he's saying that in a very leading way. And it's hard for you as the expert to combat that. But Dr. Ratner did it very graciously. She says, yes, the literature does support that glue causes this. However, the history that my patient provided showed no history of glue. So, that's not relevant to this particular case.
Yeah. Well, that was really exciting that both your presentations, but especially that cross-examination. So with that, I don't see any new questions up on the board. I want to thank everyone for participating and for sending in questions, Lauren Murphy, Edward Krenzelok, and Alan Wolf, and most especially to AACT and Mr. Alan Bell and Dr. Marcia Ratner. Thanks again, and see you next month.
Thank you, Rama.
Thanks a lot.